you very much. I have an admission to do that. When I signed up for this topic, I didn't imagine how difficult it's going to be to collect data about this. For obvious reason. One, this is a very heterogeneous disease. You already seen from the presentation before how they can have spine symptoms, peripheral arthritis, IBD, uveitis, bowel symptoms. And to talk about each one specifically is going to be very difficult. So you will notice in my presentation, I'll be using data from the gastroenterologist literature and also from the rheumatology literature. These are fairly relatively new drugs, although they've been in presence for the last 15 years. There is no clear guidelines for any major association, specifically in the IBD, but there is other guidelines in other conditions like rheumatoid arthritis, we're going to touch upon. So what I'm going to talk about, this is my agenda. I'm going to talk about why we need to optimize preoperative care in IBD patients. I'm going to move on to talk about risk factor for preoperative complication. Who are these patients that we should suspect that could have a complication or be more careful on optimizing their management? Then I'm going to talk about the role of conventional DMARD prior to the biologic area. Then I'll move to the main topic, which is the biologic DMARD and the perioperative area, and we'll end up on using the vaccine in patients who receive biologic agents. So it's not moving here. Okay. I don't want to go into the details of all the slides because these are the typical algorithm you see. And when you see a patient and you want to do a preoperative assessment and talk about the cardiac assessment, the reason I put this up, when we talk about patients, whether they are symptomatic in terms of cardiac event, like have shortness of breath, chest pain, or not, they always talk about clinical risk factor. And you can notice here in the middle of the slide, when they talk about the clinical risk factor, so if you have a patient who had a functional capacity more than 4 minutes without any symptoms like shortness of breath or chest pain, still you have to consider clinical risk factor like diabetes, hypertension, hyperlipidemia, smoking, family history. You can notice they have multiple arthritic conditions there. They have rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis. I will add to this list specifically in my word, lupus, even inflammatory bowel disease. Why? Because we know there are several studies showing that these patients are at high risk of complication, including thromboembolics, cardiac events, infections. So you can see that we should be asking these patients and consider them actually a higher risk than the general population. I think most of us has like a knee-jerk reflex when we ask about cardiac, they all ask about diabetes, hypertension, and forget that these patients are actually at risk of having complication. So please consider inflammatory condition like IBD, rheumatoid as one of the clinical risk factors. Now, to talk about who we should be care about, or who should be more concerned about having complication. There is very scanty information in the IBD literature. This is one of the paper I found in the gastroenterology literature talking about the advanced age as a risk factor of having complication. So these people, these looked into actually a fairly big number of patients who have been taking infliximab and also adalimumab. 3% of this cohort were patients who have aged more than 65. And this is the breakdown into the two diseases, whether it's Crohn's and ulcerative colitis. 78 patients who were receiving infliximab and 17% who were receiving adalimumab. This is those who are above 78 have 11% risk of severe infection. So the message here is advanced age is a risk factor. I think our gastroenterologist also in previous session talked about advanced age as a risk factor. So please be careful on those these are diseases that can last for life, and the people are taking biologic for a long time. And all of us has patients on the clinic who have been taking it for at least 10 years or 15 years. And we are seeing there is a prolongation of their life, and we are seeing them in high. They may need surgery even for other conditions not related to the bowel. They may need a cardiac surgery. So this is one of the risk factors you have to be aware of. Now, talking specifically about the IBD, here this is a paper published in the Gut journal, one of the important journals in the GI, talking about the preoperative biologic therapy and short-term outcome of abdominal surgery. Now, when I said it was difficult, because when we talk about rheumatology, we mainly talk about orthopedic procedures. I consider orthopedic procedure relatively a clean surgery, and the abdominal surgery, I excuse my French, is more a dirty surgery. So anything between the pelvis and the diaphragm, there is gut involved, there is bacteria. So when you read these literature, you have to be careful about which one you're talking about, orthopedic procedure or gut procedure. There is no question that the abdominal surgery are higher risk of having complications, specifically with infection. So in this paper, they had reviewed 473 procedures were reviewed. 190 patients were exposed to biologic, and they have at least a double number for control. So the outcome they were studying, they studied any postoperative fever, UTI, pneumonia, bacteremia, readmission. So there was a multiple outcomes measure. The procedure on biologic will have more wound infection versus control. So you have 19% versus 11%. And if you use a concomitant biologic plus thiopurine, which is whether it's an Imuran or azathioprine or 6-MP, the risk of UTI also were higher, and also with the wound infection. So the message here, definitely people who were taking biologic, they were at risk of having wound infection. And if you're using a biologic plus other immunosuppression, your risk also goes high for UTIs. This is a nice slide that I took from the US registry. These are 3 paragraphs talking about the number of prosthetic joint infection. This is an orthopedic literature talking about prosthetic joint infection in US, in the whole US. So they have data where they can tell any prosthetic infection in the whole United States. So this is a total hip replacement, total knee replacement, and those who have both. And you can notice that we have the introduction of biologic around 1999. So they talk about these are the actual incidents from 2001 and 2009. And then the dotted line are the projected. So you can see the lines, actually all lines goes up. There is a projected that the rate of infection, of prosthetic infection, is going higher. And there is a lot of effort right now trying to understand why the infection is going higher. Obviously, biologic has been blamed, since you can see the trend started here, and that's where we have the biologic came into the market. But there is other risk factor, which I'm going to talk about. So this is one of the most important things. I think this is the most important slide, and this is the message that goes to everybody. We are using too much steroid, all specialty, all around the world. Whether it's under the umbrella of stress dose steroid, treating flare, we are using too much steroids. In the rheumatology literature, people are concerned about biologic agent because it may increase in wound infection by 1.5 relative risk. All our literature review that if you are on a higher dose of steroid, and by higher dose steroid I mean 15 milligram, your risk of infection goes 4 times higher. So the steroids are way more riskier in terms of infection comparing to biologic agents. I think most of the people probably in this room will be concerned more about biologic, but I think they should be concerned about steroids. So this is a meta-analysis of observational studies. And now you can take because it's an observational study, so there is obviously some limitation. But they took a full journal article published after 1965. They specifically looked into IBD undergoing abdominal surgery. You can see when I told you there is a scanty information, there was only 7 studies specifically addressing these questions. They looked for risk of all postoperative complication, and the relative risk or odds ratio was 1.4. So obviously anything above 1, the risk is higher. If you look specifically into the risk of postoperative infection complication, it goes to 1.68. And these numbers you can range between 1.5 and 2. So I think safely you can see there is at least double the risk of infection if you're on a biologic and going into abdominal surgery. But look to if you're having a higher dose of steroid, and in this meta-analysis they define higher dose of steroid more than 40 milligram, the risk goes above 2. So the message is very clear from this meta-analysis. Steroid is even riskier than biologic agent, and we should be able to, or we should at least try to minimize the exposure to steroid, and I'm going to discuss how we can do that. Steroids, whether it's an absolute dose or a cumulative dose over time, it's risky. Frequently DMARD discontinued preoperatively. So most of the practice has been, if you're going to plan to have an elective procedure, obviously if you're having an emergency procedure, that's a different story. If you're planning to have an elective procedure, most of us probably going to stop their DMARD, whether it's a conventional or biologic, but we'll talk about the conventional part. And then the knee-jerk reflex happening, we're going to increase their steroids because we're not going to give them a chance to flare after surgery. So there has been a practice where we doubled the dose of steroid, again, under the umbrella of giving a stress dose steroid or even to preventing a flare. But I don't think that should be the right practice. Increasing daily steroid to cover a flare, we'll talk about it. And also we're talking about the secondary adrenal insufficiency. So sorry. This is a test, probably will not do it that often, but I think it should be done. This is a test, what we call an ACH stimulation test. It's a very simple test. You basically want to understand the adrenal function, if you want to see if the adrenal is suppressed or not. So you're basically giving an ACTH with dose of 250 mics, and then you're measuring cortisol level at the time before you give the injection and 30 minutes after you give the injection. If you have any number in any of these three measures above 20, you don't have an adrenal suppressed patient. This patient does not need to have a stress dose steroid. You can argue about the limitation of this, but there is, I think, a good evidence to say that if you have an ACTH response of cortisol level more than 20, your patient probably don't need a steroid stress dose. If the test results indicate adrenal gland insufficiency, or if the testing cannot be obtained, then obviously you need to initiate the preoperative period. Now, this is, I think, also a very important message that should be conveyed to the, people who are taking care of IBD patients. Once we talk about abdominal surgery, I think everybody will hear, oh, he's going to have a major surgery. This is a table from UpToDate talking about stress dose of steroid in different surgeries. Now, you can focus here on the moderate part, where they saw the moderate risk for adrenal insufficiency or complication. Actually, hemicolectomy is a moderate. They only have major cardiothoracic surgery, Whipple procedure, liver resection, and pancreatitis as a case of severe. Now, these are not written in stones, but these are suggested steroids to be given to this patient. So typically our patient probably may have a structure that needs to have a resection or bowel resection. This is actually considered as a moderate risk for stress. You can only give 50 milligrams steroids. Now, it's a different story if you're having a patient, let's say a patient is already taking a 10 milligram prednisone. 10 milligram prednisone, if you really can do your ACTH testing and you want to give a stress dose steroid, you can double the dose for 24 hours, half the dose for the next 24 hours, back to the baseline and the day 3. That's definitely not the case in my hospital and also in other hospitals, and hearing experience from other people. Most of people you go in, you see they're in 50 milligram hydrocortisone TID, sometimes even 100 milligram hydrocortisone TID, and this is a super mega dose, and those are the people who are getting complication after the surgery, specifically infection. So we should be discouraging people. If you can't measure ACTH, please do ACTH. If you have a cortisol level more than 20, you probably don't need a stress dose of steroid. I already told you steroids are risk factors for having infection. If you can't do ACTH or for other reason you can't perform the test, then you can give the steroid double the dose for 24 hours, half the dose for the next 48 hours, back to the baseline in the day 3. That's going to improve your patient chance of not developing infection and also had a better wound healing. What about other conventional DMARD? So this is a randomized controlled trials, prospective randomized controlled trials of 388 patients who have rheumatoid arthritis. So this is not an IBD patient, this is a rheumatoid arthritis who are undergoing orthopedic procedures. They were randomized to continue or withhold methotrexate. Fewer complications when not even a methotrexate. The bottom line, or the big association in rheumatology field, we do not help methotrexate. I think you can make an argument, methotrexate is probably not the most common drug used in IBD. They probably use more azathioprine or 6-MPs, but at least from the rheumatology literature, it's pretty safe, and most of the association would not go to recommend to continue methotrexate pre-operatively. Based on this one randomized control and other small data, the Canadian Rheumatology Association went and gave the strength of evidence A, which is obviously the strongest evidence you can get in terms of methotrexate can be safely continued in the preoperative period of rheumatoid arthritis patient undergoing elective orthopedic procedure. Again, there's some limitation. We're not talking about bowel surgery here. We're talking about orthopedic procedure. This is an RA patient. Again, and methotrexate is not really the most common drug used in IBD patient. But if you move to the second recommendation, which talk about the biologic agent, this is obviously a different recommendation. The level of strength goes down from A to C, and all what they say basically in the whole paragraph that you have to consider patient individually. How severe is the disease, what kind of biologic, what's the half-life of the drugs, what other concomitant medication. So it's a more complicated question if it comes to the biologic agent. This is the whole literature up to 2014. You can see there's nothing after actually 2006, but this is actually up to 2013. And all the retrospective and prospective studies that went and studied the question is whether you need to continue methotrexate or hold methotrexate prior to an orthopedic procedures. You can see the most important line, the column is here at the end. We can see most of them, they would not recommend to hold methotrexate with exception of 2. But I already told you about one randomized controlled trial which showed no evidence of increasing risk of infection. So most of the association will say it was safe to continue methotrexate in orthopedic procedures. Now, what about the other DMARDs? We talked about sulfasalazine, also azathioprine and 6-MPs. There is a retrospective studies of 367 joint surgery in 204 RA patients. Two-thirds of them were taking DMARDs, whether it's plaquenil, hydroxychloroquine, azathioprine, methotrexate. There was no association with the preoperative infection, and sulfasalazine even appeared to be data to be protective. Again, and bottom line, all conventional DMARD, including sulfasalazine, imuran, 6-MPs, methotrexate, there is no evidence to suggest the increased infection, so I think it will be safely to continue these medication. This is the data from the Corona registry. This is a US registry where they have RA patient followed, and they ask the question whether the high rheumatoid arthritis disease activity is associated with increased risk of infections. These are the different color of the line, just talking about different way of analysis. The DAS28 score is the disease activity index that we use in RA, basically examining 28 joint and looking for any tenderness on effusion. In the x-axis or the y-axis, you can see the outpatient infection rates. As you can see, if your disease is more active, your risk of infection goes higher. I believe the previous speaker has shown also similar data in the IBD. The more active your disease, the more chance that you have infection. I think it's going to be complicated by the fact that probably these are the patients where you're going to be more aggressive and using more medication, including biologic agents. This is also another piece of evidence from the British registry looking for the rate of serious side effects were similar across all the biologic treatments. Now they define SIs as were defined as those who would need hospitalization, death, required intravenous antibiotic treatment. This is just to show that if you look across all the biologic aging, I'm talking about specifically about anti-TNF here. Now in IBD, we always using adalimumab and infliximab, not etanercept, and the risks are similar. So the risk for adalimumab was 1.07, and the top one, the 51.9 and 55.2. The message from this point, they're all having similar risk. All anti-TNF hold the similar risk in terms of infections. We talked about the anti-TNF with the risk of skin and soft tissue infections, specifically wound infection. We're talking about the preoperative period, but also there is a piece of evidence showing that patients who are taking anti-TNF have more chance or more likely to have a persistent colonization. So obviously, if there is a persistent colonization, and that's where the site you're going to do your incision, there is a chance that you're having a problem with the wound, including infection and wound dehiscence. So just looking specifically into IBD patient, I only found these studies and maybe other studies I couldn't come across talking about infliximab and Crohn's disease using of so this was published in 2008. They're talking about the use of infliximab within 3 months of ileocolonic resection, and it's associated with adverse post-operative outcome. This is a small studies. I think there was like 50 patients, but they're talking about increased risk of infection, and there was, when they calculated the odds ratio, it was 1.5. So again, you see the same theme is coming up with the same number between 1.5 and 2 odds ratio. This is a study published by Dr. Susan Goodman, who is from United States, and was published in Arthritis and Rheumatology Journal in 2014. This was an attempt to do a systematic review and meta-analysis of 11 studies, specifically linked to an adult RA patient who are undergoing elective orthopedic procedure. They pulled the data of 3,681 patients who are exposed to anti-TNF. So all these people were exposed to anti-TNF, and they wanted to calculate the risk of surgical site infection, and the odds ratio came to 2.47. The limitation, obviously, because there is no randomized control rights, and they were trying to pull all the data and only select people who were taking anti-TNF. Again, the same numbers comes up, which is the odd ratios of 2. This table is from the same table, just to give you a flavor in terms of what they looked for into the in terms of outcome. Most of them were retrospective studies, with exception of 2. They were prospective. They looked into different NT-TNF, and the outcomes were different: surgical site infection, wound healing, any complications. And again, you can see there was no major side effects except with the wound infection, which comes with the odds ratios of 2. This is from the gastroenterology literature, looking specifically into the preoperative risk of infections, comparing on those who are undergoing abdominal surgery. This is more reflective in IBD patients. Now, this is our different study from 2004 till 2013. These are yes and no, indicating whether they have found out they have a risk of infection were higher. You can see there is a couple of, well, there is a 3 yes and there is a lot of no's, and the odds ratio range from 1.2 and the highest one was 2.5. So obviously when you have a paper like this and they're heterogeneous, what do we try to do? Meta-analysis. So that was an attempt to do a meta-analysis for those who are IBD patients undergoing abdominal surgery and were exposed to TNF. To my surprise, these 2 meta-analyses were published in the same journal, in the same issue actually, and they showed different results. So this meta-analysis were based on their inclusion criteria. They have 6 studies, including around 1,200 patients, and found no significant difference in the postoperative complication rates between the group who were treated with infliximab and the untreated group. So they were specifically talking about one drug. However, the second study, which I think was more inclusive, there was 21 studies. There was a bigger number of patients. They have both the Crohn's ulcerative colitis and showed increased risk of any complication was an odds ratio of 1.25. So there's a mild risk, increased risk of having any complication, but the risk of infection was 1.45. Again, the same numbers comes around being 1.5, the risk of having any wound infection. So what to do? ACR, which is the American College of Rheumatology, they would recommend to withhold TNF inhibitors for 1 week prior to surgery. American, very aggressive. British Society, withhold therapy for 3 to 5 times of the half-life of the drug. British, conservative. What do the Canadian do? Always in between. The Canadian Rheumatology Association withhold the therapy for 2 half-life of the therapy. Typical scenario, we see it all the time. Aggressive people, conservative, in between. So what do I do? Balancing the risk of postoperative flares versus the risk of infections. So these are the half-life of the common drug that use in IBD. The one in the red, the one we use in IBD, whether it's adalimumab, infliximab, or cetirizumab. So for adalimumab, the mean half-life is around 14 days. For infliximab, let's say 10 days, and for cetirizumab is 14 days. So 2 weeks for adalimumab, almost 2 weeks for infliximab, and cetirizumab is 2 weeks. So I think the mean half-life of all of the TNF, the B, is at least 2 weeks. So if you go with the American, you really have to hold your anti-TNF for only 2 weeks. If you're going to follow the British one, you're going to hold it for at least 6 weeks. If you're going to follow the Canadian guidelines, you're going to hold it for a month. Now, these are the recommendations for orthopedic procedure. I think I'm neither with any of these recommendations. Because it's about surgery, I tend to be more conservative, and I think it'll be safe to hold the drug for at least 3/2 of the drug. So for adalimumab, for example, I will hold it for 6 weeks. The same thing is going to be for cetirizumab. If you give it once a month, I will hold it for at least 2 months. And the same thing it goes with infliximab. Again, these are my understanding of the literature. There is no guidelines of any of these associations, also from the gastroenterologist. So when all these guidelines talk about balancing the risk of having a flare postoperatively and also having an infection preoperatively. So what are the predictors? You need to know about the type or the site of the surgery. Abdominal surgery, more risky than peripheral surgery. Comorbidity, if you're diabetic, your risk of infection is higher. Previous infection, if the patient is known to have an MRSA wound infection in the past, obviously you're going to be more concerned about this patient. Type and dose of immunosuppression, I'm talking about other concomitant immunosuppression, whether you're using azathioprine or 6-MPs. So you need to really balance all these factors to decide how long you're going to hold your biologic agent. This is the take-home messages. These are from the Canadian guidelines. So if you're talking about the conventional, so they would not recommend to hold any of these DMARDs before the surgery, and they would recommend to continue all these conventional. It's a different story if you're talking about the anti-TNF. If you goes with their guidelines, again, it's 2 half-life. I'm a little biased. I told you if you're doing an abdominal surgery, I'll go with a 3 half-life. So this was my first part of the talk. So we'll switch gear to talk quickly about the vaccination. Again, very complicated. There is a lot of cofactors talking about here. I'm just going to start with quoting from Dr. Jeffrey, where it never been in the history of a human progress that has better and a cheaper method of preventing illnesses being developed than immunization at the best. Over the last week, there has been a big buzz about H1N1 and other influenza. I think there was Twitters and Instagrams. Everybody was scared. There was not enough vaccine in the polyclinic and the hospital. And unfortunately, even talking to my colleagues in the hospital, there's so many resistance, and they said, oh, this is all company driven. There's no need to give all these vaccines. They're talking about comorbidity. And really, in those patients who are immunocompromised, I'm talking about those who've been taking biologics or other immunosuppression, they are at risk. And I think we should be encouraging taking vaccination since they're safe. So what vaccination we're talking about? I'm not going to go through the whole list, just to tell you there is a live attenuated vaccines and there is an inactive killed vaccines. In the United States, in the last few years now, they're using the the nasal influenza vaccines, even for kids in the school. This is a live attenuated. It's not available in Kuwait, but it may at some point come to Kuwait. These live vaccines should not be given a patient who be taking biologic agents. So what do patients with autoimmune rheumatic disease have normal response to vaccine? I think this is the big questions. There is a lot of factors to make a decision about this. The type of the drug they're using, the disease that you're dealing with, rheumatoid, inflammatory bowel disease, lupus, it's a totally different population. Advanced age, I'll give you an example. If you give a patient pneumococcal vaccination, 80% of general population will respond to pneumococcal vaccination. However, 20% from general population, which are normal, will not respond to pneumococcal. So there is a lot of factors involved in deciding whether you want to give or not. Comorbidity, we talked about patients who have immunosuppressed or they have autoimmune condition. History of prior vaccination or prior vaccination reaction, plus infection. I guess the big sphere in the medical field, if you talk to a physician, it's different when you talk to a patient. If you talk to a physician, they're going, oh, there was a case when we were trained, there was a nurse who developed Guillain-Barré. I don't think we're going to get the flu vaccine. And that word spread so quickly in the hospital, and you can see nobody's getting their flu vaccine. The patient's concern is not really long-term or the immediate term. Would it be protecting me? And I think there is evidence to show that it will protect the patients from getting admitted to the hospital. When I started in Mubarak Hospital, there was no routine schedule to give vaccination. I don't have data to back, I don't have study, but my colleagues can tell there is less people getting admitted to the hospital with pneumonia, UTI, or urosepsis after we start the vaccination program. So anti-TNF and blocking again is some comments. So these biologic maybe reduce antibody response to influenza vaccination, although it's not enough to say it's not worth doing. There is a multiple evidence, some of the studies showing a normal response, some of the studies showed not a very strong response. But overall, they were safe. There was no adverse event in people who was getting these anti-TNF and giving the vaccination. There are conflicting data about the seroprotection achieved. That's another limitation of the study. Everybody talk about the antibody response, but I don't really care. Well, I do care about the antibody response, but I do care more about the infection, whether the patient actually developed pneumonia and needed to be admitted to the hospital and receive the intravenous antibiotic. These studies usually short, so they don't really tell you about admission rate and needed to antibiotic. They only talk about antibody production. I'll give you two examples. This is a study published in 2012 by Frank et al. They reported decreased antibody response in RA patients and SPA patients to influenza vaccination in a patient on infliximab and adalimumab, but not in etanercept. There was another study in 2006 prior to that reporting a significant decrease in post-pneumococcal vaccination titer after just 18 months of an RA and SPA patient. There is some conflict. I think the bottom line, you should get that. There is no major adverse events of giving influenza. It's a killed vaccine. I would encourage patients to take it before they start the biologic agent to improve their chance of having antibody response, and also I would recommend to take it on a yearly basis. This is a slide from the Canadian Rheumatology Association talking about the recommendation whether to give vaccination if you were taking methotrexate. So there is a check mark on taking influenza, pneumococcal, hepatitis, a check mark with a zoster, but this is a live attenuated, so there's special circumstances. We'll talk about it. Again, the same check mark goes for methotrexate, leflunomide, sulfasalazine, and biologic. So they would go and recommend with a strong recommendation to give pneumococcal influenza on a yearly basis, pneumococcal every 5 years, and hepatitis B if your antibody level were not protective. Now, in terms of the herpes zoster situation in Kuwait, it's not available in the government, it's available in the private. Even if you got a chicken pox when you were a kid, your antibody levels goes down as you age. So there is study showing, I'm not talking about people on anti-TNF, I'm talking about general population. There is study showing that if you get a booster of a zoster, there is a better protection if you develop like a zoster complication, specifically zoster neuropathy. All of us seen patients in zoster neuropathy, and it's not a pleasant disease to have. So if you give a booster vaccines for a zoster, that will reduce your risk of having comorbidity. If you talk about my population or the people who have an IBD, these even at riskier population. One of the new drugs that's coming for IBD is the JAK kinase inhibitor. And initially with the randomized control, there was a mild increase of risk of having zoster activation. So I personally, before I start my ballot, because it's a live attenuated, I will go ahead and give the vaccine if it's available. But it's not in the government, patients have to go to the private. Now there is another special circumstance. We were in San Francisco a few weeks ago in the American College of Rheumatology, and they have a medical student who have ankylosing spondylitis, who went to do start a rotation in a hospital, a pediatric hospital, and they tell him you don't have a protective antibody to MMR. So they force him to do MMR vaccine. So he is taking anti-TNF, so he went back to his rheumatologist and said, what am I going to do? I can't do the rotation, I have to get the protective antibodies. So the rheumatologist, what he did, he actually held the anti-TNF. He told him you have to hold it for 3 months. By second, he held it for 3 months. By second month, his disease flared. He actually was crippled and stayed home. He couldn't even go to work because the anti-TNF was held. He waited another month, got his vaccine, and went back to the anti-TNF. So this is not a very common scenario, but it can happen, and you have to consider that with patients taking a live vaccine. So, I mean, the other common one, obviously, will not taking a yellow fever if you're going to an endemic area, but I think the zoster one is going to be the most common scenario if people ask you about live vaccine. So, core adult vaccination, I would recommend taking influenza every year, pneumococcal every 5 years. This is the recommendation, even for general population, and it would be safe also taking people who are taking biologic agent, whether you update your tetanus, diphtheria, antibodies. We talked about the zoster. Get the antibody tested for hepatitis B surface antibody, and if it's not protective, you can give a boost for hepatitis B. And the human papilloma virus, that's a special circumstances for special people. I told you about the new intranasal one. It's not available in Kuwait. This is the common one in Kuwait. This is trivalent. It's inactive. It's very safe. Unfortunately, we have a problem with the shortage of the vaccine this year. So that's why you see a lot of things came in the social media talking about who should be going to the polyclinic. I was in the hospital last week, and the preventive medicine department was overwhelmed with all these people showed up because of the panic happened in the society. Pneumococcal, there is 2 vaccines. There is the polysaccharide, the 23 serotype, and that's the one we recommend to the adult. There is the conjugate type, which has the 13 serotypes. Now, different society recommend different one. I know for a fact the one that's available in the hospital is the adult polysaccharide. I would recommend to give it every 5 years. Interval against parity depending on the age, and the American College of Infectious Disease recommendation to go beyond the FDA, which is even more generalized in terms who should be getting. They recommend to take anybody with comorbidity, COPD, asthma. They have a huge list. If anybody have a comorbidity, they can take this vaccine. This is a recommendation specifically for giving pneumococcal vaccination in immunocompromised person, which is an adult more than 19 years old, whether you're taking prednisone 20 milligrams. We don't consider this in patients. We have a lot of patients who take prednisone for a long time for many reasons, many specialty, and we don't think that on a daily basis. Or taking biologic and other immunosuppression. Specifically, this is an American recommendation talking about giving the conjugate type, which is the 13 serotype, followed by the other one, the polysaccharide one, the 23 serotype, at least 8 weeks apart. And administrative a second dose of the 23rd at least 5 years after the first dose. So we don't tend to do that normally, but that's the American recommendation, to give the 13 serotype followed by the 23 serotype after 8 weeks, and then repeat it every 5 years. We give one pneumococcal 23 in the hospital every 5 years. The tetanus we talked about, it's general, for general population, you have to update your tetanus every 10 years. I would ask the patient if you have got any, they may have a wound, they may have an injury and they went to emergency and their tetanus was updated. If not, I will update their tetanus. Zoster vaccines, adults who are more than 60, vaccine are reduced the shingle in 50% and the post-shingle pain is 67%. These are very impressive pain. You have to talk to one of these old people who develop zoster neuropathy, and you'll know it's a very painful conditions, and I would offer that vaccination for them. The American goes and recommend for all healthy adults with more than 60 who are not immunocompromised. The ACR, the American College of Rheumatology, recommend to have vaccination prior to the immunosuppression. And this is where they're important. When the patient comes to the hospital, you're already doing your workup, PPD test, chest x-ray, hepatitis screen, you're sending for liver function. You do have time before the patient goes on the biologic. I think this is the gold opportunity to update his vaccine. I always give them a paper to go and visit the preventive medicine department in my hospital, and they do a fabulous job in updating their vaccine, whether it's influenza, pneumococcal. They will tell them about the zoster to go outside and also update their tetanus. That's all. Thank you very much.